All right. Hello, everybody. Welcome back to Women's Health. You all did very well on your exam. If you would like to see your exam, open it up and see what you got correct or what you missed, you're welcome to visit me or visit Shada during our office hours. She has more office hours than I do, so she might be a little bit easier to catch, but just sort of know that is an option for you all. Okay. Today, we're going to cover cardiovascular disease. So let me go ahead and screen share my PowerPoint. All right. Pre-pandemic, cardiovascular disease, leading cause of death for women and men in the United States. And number one cause of death is coronary heart disease, which is normally a heart attack or a myocardial infarction. Number three cause of death would be stroke or cerebrovascular accident. But somebody please shout out for me if we were to go out and interview people on the street and ask them what the leading cause of death for women was before the pandemic, what would most people say?
Breast cancer?
Thank you. Yes. Yes. So, I mean, and cancer is the second leading cause of death for women, but as we're going to see in the lecture after this one, it's actually lung and bronchial cancer that is the leading cause of death in women, and breast cancer is after that. So lots of people, it makes a lot of sense to me why women fear breast cancer, and why they oftentimes people think that it is the leading cause of death for women. Okay, so cardiovascular disease, half of all mortality for women. Okay, and I want to talk about the American Heart Association's Go Red for Women campaign. And this has actually been a very successful campaign because what it's been trying to address is that myth. So that myth that breast cancer is leading cause of death, women don't ever get heart disease, women don't have strokes. And what we see when women do have a heart attack, they oftentimes themselves don't recognize the symptoms. And then, like we've talked about already this semester, first responders and even emergency room medical doctors tend to be less aggressive in running diagnostic tests and tend to be less aggressive in actually treating heart attacks when they occur. Some of the reason for this, though, is I want you to know that when men are having a heart attack, they're a lot more likely to have crushing chest pain or feel like an elephant's on their back and kind of crushing them from the back. And they're more likely to have pain that radiates down their left arm. Women, on the other hand, are more likely to have gastrointestinal upset, so stomach upset. And then women's heart attacks tend to come on a bit slower. They can be like a massive, very quick heart attack, but there's more of a sense of fatigue. And so oftentimes women are, even when they're experiencing symptoms, are like, oh, I've just been working really hard, or I haven't slept well, I'm tired, or that they're just anxious and having heart palpitations, or that they've got an upset stomach, as an example. Another reason why everybody gets fooled a little bit is that women's cardiovascular disease tends to have an onset about 10 years later than men. And so much of that is due to the fact that we women are protected against cardiovascular disease up until menopause. So around the age 50 to 53, we see women's risk of cardiovascular disease escalate, but before then we're protected. And a lot of the reason why we are protected is that we have higher estrogen levels than men do. And estrogen tends to make our arteries and our veins nice and elastic. Okay. And the reason we think evolutionarily and biologically that our cardiovascular system is nice and elastic is it allows for us to carry a lot more blood volume when women carry a pregnancy. Okay. And so it's at menopause when estrogen levels drop dramatically that women start to take on the cardiovascular disease that men have had. Okay. So estrogen protects us. When women do have cardiovascular disease, they have more resulting illness because of it. Some of that is due to the later onset because they're oftentimes older. Some of that has to do with this less aggressive treatment. When women have cardiovascular disease and they have an event, they're more likely to die than men. And women tend to be underrepresented in clinical trials. Okay. And more recent clinical trials have changed that because particularly National Institute of Health, when they have funded research, requires that researchers include women in their studies. And remember that they used to like to not include women in their studies because they found the menstrual cycle to be a nuisance. But again, from a women's perspective, like if the menstrual cycle is impacting medicine or cardiovascular disease in some way, don't we want to know? And so you've got to include women in the trials to sort of understand how women respond. Same type of thing for including individuals of varied races in clinical trials to know how race might be interacting with responses and outcomes also. Okay, I'm going to stop share. I want to show you one of the campaign clips for Go Red. And this is Elizabeth Banks. I love Elizabeth Banks. She has been a part of this. Let me get the large screen so you can see. Okay, and she has a humorous kind of take on how women tend to respond when they're having a heart attack. So
like a totally normal day. Okay, move objection deadline to the third line after survey. Oh, honey. Oh, you always use the verb to start. Did you finish your breakfast? Ow. Ooh. Don't hit your brother. You have to eat something. Here. Okay, 5 minutes to carpool. Coffee.
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly. Spaghetti. You sure you're okay?
I'm fine, sweetie.
I'm so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorites. See you guys later.
Where are your shoes? Put your shoes back on, please. Go help your sister. We're going in 3 minutes. God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, here. Nobody move. I'm getting a dustpan.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. Totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
I'm going to go ahead and play this while we're here, but you'll see that there's a link for this here in a bit, and then we'll talk about, if you want to talk about the campaign. But I want to show you just some real basic anatomy here.
About the size of your fist, the human heart is the most important muscle in the body. It can beat more than 100,000 times a day, pumping about 2,000 gallons of blood through a 60,000-mile network of vessels in the body. The human heart is made up of 4 major chambers. the right atrium, right ventricle, left atrium, and left ventricle. The right side of the heart receives blood that is low in oxygen from veins all over the body. It then pumps the blood through the pulmonary arteries into the lungs where it will become reoxygenated. The left side of the heart receives this oxygen-rich blood from the lungs. Then it pumps the blood through the aorta back out to the rest of the body through a complex network of arteries, arterioles, and capillaries. While blood is circulating through the body, it delivers oxygen and nutrients to tissue through the capillaries, and at the same time picks up carbon dioxide and other waste material. The veins return the deoxygenated blood to the right atrium, and the cycle begins again.
Okay, I don't want to show that.
The heart has 4 valves.
All
Each
right,
valve.
you can stop talking now, Di. Okay. So what do you think of the Go Red Elizabeth Banks campaign? She showed it with a sense of humor, certainly, right? The part that cracks me up the most is when she looks at the mess in the house, you know, it's like, can you make it 10 minutes? Because she's kind of embarrassed how messy her house is. And I don't know if you caught the part where she was eating Tums, but she thought she was feeling nauseous and had, you know, stomach upset. So she was eating Tums, kind of trying to self-treat. So again, the Go Red campaign has been quite effective in starting to educate women, as well as educating men, that heart disease is common in women and that we should be taking our symptoms very seriously. There's an episode for those of you who are Grey's Anatomy fans where, I'm blacking on her name. Help me out here. Is having a heart attack. Bailey. Yeah, Bailey's having a heart attack and she checks herself into a hospital and nobody believes her. And then she's just like, I'm going to stay here and ask for you to run these tests until you figure out. And then she has quite the heart attack after all the doctors are saying, oh no, you're not having a heart attack. Miranda Bailey. Okay, so a little bit about cardiovascular system. We just watched that little educational video. I just want you to know that the heart's about the size of a fist, and it is a muscle, and it's a unique muscle in that the fibers in the muscle all beat in synchrony. And because it's a muscle, should an individual have a heart attack where some of the muscle tissue dies, which we call an infarct, and I'll get to that a little bit more later, it is possible for a muscle to heal if it has not been damaged too much. Okay, and then we're going to talk about cardiac rehab as key to helping the heart heal after a heart attack. The coronary arteries are the arteries that feed the heart muscle its blood. And if you think about sort of from a plumbing standpoint in the body, those arteries that feed the heart, because all of the blood keeps coming back to the heart and then going out to the rest of the body, get a lot of volume and a lot of traffic over time. So it's no wonder when cardiovascular disease is building up in the arteries, they're likely to show up in the coronary arteries that feed the heart its blood. Okay. And then obviously blood is carrying nutrients, it's carrying oxygen, it pulls that oxygen from the lungs in the heart and then pumps that oxygen back out to the body. It picks up the carbon monoxide and any kind of leftover materials from nutrients and pulls that out of the body. Any questions here? Basic anatomy stuff. Okay. Let's define coronary heart disease. So this would be an illness where the arteries that supply the heart with blood, they narrow or they get clogged. And because of that, they're depriving the heart tissue on the other side of that narrowing or the other side of that clogging with blood. So if this was down here, if this is a normal artery, you're going to get nice blood flow going through here. Here we've got some mild atherosclerosis. So you're seeing it's both narrowed inside as well as we've got this kind of buildup right here of this plaque. And then severe atherosclerosis, if this were a coronary artery, that person would most definitely be experiencing a heart attack here because they're missing quite a lot of blood flow at that point. One way of thinking about what happens in the interior, particularly if an individual, for guys, it's a big surge in systolic blood pressure. For gals, it's more of a surge in heart rate. that you can get these injuries inside an artery, just like you can get an injury on the outside of the body. And when there's an injury to the endothelium, which is the lining there, then they're going to get some lesions or tears. And just like you would see an injury on the outside of the body, it's going to lay down this fibrinolysis, this scabbing system. And then the immune system is going to detect an injury, and it's going to send in macrophages. It's going to send in its stuff trying to clean up that injury. And if you think about what happens after that point, you've got this healing response that is being attempted here. And then if an individual has just consumed cholesterol, potentially, or especially the LDL, the low density lipoprotein, remember that's the one we want to be lower, then that fat, that cholesterol is going to start to collect where that injury is and where that fibrinolysis and that scabbing and that attempt to heal the injury is happening. And so we call this plaque buildup atherosclerosis. So that's the plaque. And keep in mind, we've been talking about coronary arteries, so arteries that feed the heart. The same process could be building up in the blood vessels in the brain. And if that's happening in the brain, then that individual might be having a stroke or a cardiovascular accident. So when it happens in the heart, we call it a heart attack or a myocardial infarction. When it happens in the brain, we call it a stroke or we call it a cerebrovascular accident. My son asked me when he was younger, he's like, if you call it a heart attack, why don't you call it a brain attack? And I'm like, I don't know. I don't make these things up. Other people do. Okay. So coronary heart disease is the arterial sclerosis is when the arteries start to harden, and you can have both of these processes going on at the same time. So the arterial sclerosis, they're hardening, they're not as elastic. Makes a lot of sense why that starts to happen more in women post-menopause, because they're no longer protected with that nice estrogen. And then the atherosclerosis, the plaque buildup, these things tend to be happening at the same time. That's going to cause the coronary heart disease. And how much severity there is going to determine how much damage. So if there's teeny tiny severity, a person could, not even really notice that they're having a teeny tiny heart attack. If it's major severity, they're going to go down and potentially die. Okay, some other terminology and other kinds of types of diseases or other things that are happening with coronary heart disease. Angina pectoris, these are the pectoris muscles here, and angina pectoris is when there's a tightening or pain that's happening in this area of the body because of restricted blood flow. And we call the lack of oxygen that is happening to the heart tissue ischemia. Okay. And that angina, that pain from that lack of oxygen and that ischemia, it can be happening only when that person exerts themselves, which is why it's dangerous for somebody who's out of shape to go shovel snow in their driveway, as an example. That's really dangerous for some individuals. And you hear about people having heart attack and dropping when they're doing that. For other individuals, it's called unstable angina. It could be happening anytime, even when they're sitting or resting. Or it could be happening only when they exert themselves. It's part of the reason why when doctors do a stress test to check the integrity of the heart, they will put people on a bike or put them on a treadmill and let them exert themselves to see what's going on with their heart and their blood pressure. A myocardial, what we're seeing here is the muscle of the heart tissue, and an infarct is when tissue is dying. Okay, so a myocardial infarction or an MI is what we classically call a heart attack. Okay, and it's when that coronary artery is blocked, so that heart tissue is not getting oxygen and the heart tissue starts to die. Now, keep in mind, it takes longer for heart tissue to die, whereas brain tissue dies much quicker. Okay, so a stroke is much more of a medical emergency. A heart attack is a medical emergency, but a stroke, a more immediate medical emergency, because as this clogging is happening in the brain, you're going to get brain tissue death much quicker than you're going to get heart tissue death. And so the infarct is when tissue's dying. And then a cerebrovascular accident, what we normally call a stroke, is when this same process is happening somewhere in the brain. If it's teeny tiny blood vessels feeding a part of the brain that's not that important, it could go totally unnoticed. If it's a major, like a carotid artery feeding the brain and it gets totally clogged, that person's going to die of that stroke very quickly. Okay. 2 types of stroke. And remember, stroke's number 3 cause of death. The coronary heart disease is number 1 cause of death. The ischemic stroke is the most common type of stroke that we see in the United States. And that's where you get those clogged arteries or those narrowed, hardening arteries to the brain. A hemorrhagic stroke is normally, this is a bleed. You've got the brain is bleeding out somewhere as opposed to it's clogged up and it can't get oxygen. Hemorrhagic stroke is a lot more commonly seen in an injury. So some kind of head injury, as an example, would be hemorrhagic. The ischemic stroke, again, most common that we see in the United States, it's the same cardiovascular disease process that's building up and can damage the heart, is building up and damaging the brain. Any questions on that? Okay. We've already talked about metabolic syndrome a bit, but I just want you to know that metabolic syndrome in and of itself is going to be an increased risk factor for cardiovascular disease. And remember, we've talked about that as a large waist circumference, high on triglycerides, low level of the high density lipoprotein, the good cholesterol, high blood pressure, high fasting glucose, which is going to be either pre-diabetes or diabetes. And if a person has 3 or more of these, then they've got metabolic syndrome, which is going to be driving cardiovascular disease. We talked about this when we talked about obesity. It's also going to make it very easy for those individuals to continue to gain body fat once they have metabolic syndrome. So it doesn't self-correct. It actually is kind of synergistic. It makes things worse at that point. So this is certainly a risk factor. Okay. So when we're assessing patients for cardiovascular disease, ideally they are awake and can deliver a patient history, or their family members or friends there that can deliver a patient history. The more you have family history, genetic family history, like I've got it everywhere on both sides of my family. The more you have that family history and that genetic history, the more at risk you are going to be for cardiovascular disease yourself, as well as your personal patient history. Like, have you had a previous heart attack? Have you had a previous stroke? Have you had high blood pressure? Have you had high cholesterol levels? That type of thing. The electrical tests that they do, where they put electrodes on different areas of the front of the chest and the back of the chest. Miranda Bailey, Dr. Bailey, when she was in the hospital self-diagnosing her, she got upset that they didn't put the electrodes on the back. And she's like, women, you're more likely to detect a heart attack when you put the electrodes back there than if you put them on the front. And the young doctor was only putting them on her chest. An EKG, electrocardiogram, the K is for the German spelling of cardio. This can see if there's any dead tissue, there's going to be abnormalities in the wave from the electrocardiogram that can kind of alert, hey, maybe there's something going on here. Usually blood tests are run to look for certain enzymes in the bloodstream. When the heart muscle dies, it's going to release these enzymes and release these chemicals, and they can be picked up in the bloodstream. So there's usually blood tests that are run. An echocardiogram, where they bounce sound waves, it's the same kind of thing where they look at when a person's pregnant and they're taking a look at a baby. The electrocardiogram might be able to look for clots or some kinds of gross anatomical problems, gross meaning big, not meaning yucky. The most accurate form of diagnosis is a coronary angiography. And that is when they will thread through the femoral artery down near the groin, up into the heart, and then shoot dye into the arteries. And then taking a look on a special kinds of scan, they're looking to see Let's say this is the number of arteries and they shoot the dye and all of these arteries are getting blood flow. You can see the dye flowing through, then that's probably a nice healthy heart. If on the other hand, like let's say two of the artery, sorry, I didn't mean to give y'all the finger. If two of the arteries aren't getting full blood flow, then that means like, uh-oh, something's wrong here. This part of the heart tissue is probably, there's a heart attack happening and it's losing blood flow. This is the most accurate form of making a diagnosis, okay? And then if there are narrow or clogged arteries diagnosed after an angiogram, then there is usually in US medicine some type of surgical procedure follow-up after that. I had a woman client at one point in time where she was having some symptoms and her doctor recommended that she go into the hospital and have an angiogram performed. And she decided not to, it's kind of like Elizabeth Banks. She decided not to bother her husband or her daughters and let them know where she was on that particular day. She goes and she has the angiography and her heart is fine. So that wasn't the problem. But as she's in recovery, after they had threaded through her femoral artery, she's in her hospital bed and the plug comes loose. And then all of a sudden blood is spewing all over her. And her first thought is, maybe I should have told somebody where I'm at today. Like my family doesn't even know I'm here and now I might be dying. She was fine. But imagine how scary an event like that would be. Particularly after the doctor just said your heart is fine, and then all of a sudden spewing blood. So this is the most accurate way of diagnosing it, but obviously it's a little more intensive than these other things. So some things that we are not able to modify in terms of risk factors, age. Age is a predictor of developing cardiovascular disease, but again, women tend to be on average 10 years behind men. So you're going to see cardiovascular disease in men in their 40s and maybe even younger than that. I lost when I was in graduate school, most of us were in our 20s and 30s, and I lost a male colleague to a heart attack, and he was young. Race in the United States, we see Black Americans more at risk for cardiovascular disease than white Americans, and I'll explain that a bit more here in a bit. The family history, again, particularly if you've got it on both sides of your genetic lineage as opposed to one side, doctors are paying a lot of attention to that when they're doing yearly checkups, as an example. Low socioeconomic status is not necessarily something that people can control, so it's considered to be non-modifiable. The issue with low socioeconomic status is it's associated with so many other risk factors. And that's where the epidemiologists get in there with the data and really try to tease this stuff apart. And so this is going to be confounded by, you tend to see people of lower SES have larger bodies, higher BMIs, more likely to be cigarette smokers, more likely to have a sedentary lifestyle, and more likely to have these high cholesterol levels that are a result of the sedentary lifestyle and a result of a difference in their diet and their nutrition. So you get a lot of this kind of stuff. I attended this one workshop at a conference at one point in time, and it was about socioeconomic status in which somebody was born and raised versus did they live in that SES for the rest of their adult life, or did they, if you were born in poverty, but you were able to rise out of poverty and become middle class or upper class, these epidemiologists were looking at, could that change your health status? And what they found is that you would think it would, but it did not, at least when they were, teasing apart all the variants and all of this research. I don't quite know the reasons for all of that, but so SES tends to be what we're born in, tends to kind of live with us for the rest of our lives, unfortunately. The modifiable risk factors for women, and this is a recent systematic review, found that hypertension is something that we can modify. We can control our blood pressure with lifestyle change. We can control our blood pressure with medications. For women, and I've known some women who during their pregnancies have had preeclampsia or toxemia. And one of the earliest signs of that in pregnancy is high blood pressure. And then they get a lot of swelling, edema in the body. And then that puts them at risk for seizure disorders and death. So we talked a little bit about that already this semester. Women who develop hypertension or full-blown preeclampsia during their pregnancy are a lot more likely to have issues with hypertension later on in their adult lives. Okay, so even if they're in reproductive age and they're nice and protected by that estrogen, if they get this stuff happening during their pregnancy, this stuff is a lot more likely to happen later on in life. High cholesterol, particularly high levels of that low density lipoprotein and low levels of that good stuff, the HDL. And this can be modified with diet. It can be modified with medications and other lifestyle changes. Cigarette smoking is quite a driving force for cardiovascular disease. That can be modified. Diabetes can be treated either with lifestyle change or with medications to control glucose levels and the consequences from diabetes. The physical activity levels are modifiable, and then trying not to have a BMI that falls obese and above in range. And what you're going to see here in a bit is when we start talking about prevention of cardiovascular disease and we start talking about treatment of cardiovascular disease, you're going to see all of these things come into play. We're going to really be working on modifying this. Okay, I'll pause for a second. Anybody have any questions as we're rolling through this? Okay. So medical management, I want to talk a little bit about meds, and I want to talk a little bit about supplements. The statin medications are medications that lower lipid levels in the bloodstream. So they take the bad cholesterol and help move it out of the body. I want to tell you just an interesting story about my father and what he experienced after he went on statin medications. My father and I both have been hot-blooded all of our lives. We're the kind of folks that like in the bed, kick our legs out because we're hot at night. And I like to run in lower temperatures because I just run hot-blooded. My dad was always like that until his doctor put him on statins, which pulled the fats out of his bloodstream. And now he gets cold really easily. And it's just sort of like he doesn't have the insulation, I guess is what one way of thinking about it. Aspirin as a blood thinner, and aspirin prevents platelets from collecting and clots from collecting. And so there are a lot of individuals that are treated with aspirin after they've developed cardiovascular disease or put on baby aspirin as a preventive agent. You got to be careful with the aspirin. You don't want to overdo it because it can create bleeding, but it's preventing clotting. So it would make sense that it would make you prone to bleeding. The hypertensive medications, we'll talk a little bit more about some of those. There are a bunch of different families of those meds here in a bit. And then I was looking up yesterday and just going through the different systematic reviews because I thought vitamin D was going to show up as preventative, and it did not. Vitamin D effects seem to bounce around in the literature, but the vitamin E effect was pretty strong. And so recommendations that people are consuming enough vitamin E in their diet, or they're using supplements of vitamin E in their diet for medication management. We've already talked about this semester, the hormone replacement therapy. And thank goodness they were running the Women's Health Initiative study and tracking women prospectively over time, women who are on HRT, women who are not on HRT, because they thought it was going to be so beneficial for women. It was going to prevent them from having heart attacks, prevent them from having strokes. But what they found, they even ended these trials early, was it was creating more stroke, more deep vein thrombosis, that's where you get those roaming blood clots, more dementia, probably because it was creating more circulatory issues in the brain, more breast cancer, and absolutely no protective effect on cardiovascular disease. So I want us to kind of absorb this a bit. Natural estrogen that our body makes is really, really good for women and preventing cardiovascular problems. Artificial hormones that are usually coming from like Premarin, we've talked about this before, it's a pregnant mare, it's coming from pregnant horses' urine, Premarin. When we take hormones from other species or synthetic hormones, that is not good for us. Okay. But the thought at the time was, if this stuff is good for you in young age, it's going to be great for you in older age. But thank goodness we were studying it scientifically, because there was a lot of harm that was happening by routinely giving menopausal women HRT. Questions there? Okay. Our blood pressure is meant to be dynamic. Okay. And I want you to kind of think about this. Like when you're sitting quietly and let's say you're reading or you're on the computer, it would make sense if you decide to go out and run a couple miles, your blood pressure is going to need to adjust. And it's also going to adjust and be a function of if you are, let's say, exercising in cold weather, that's going to be very different than if you are exercising in warm weather. Okay. So as an example, I've talked about diagnosing myself as being hot-blooded. I'm one of those individuals where as soon as I start moving, I get flushed because my body's trying to kind of release heat. I sweat like a Dickens when I move around. It's kind of like my body does not like being warm. And I very much prefer exercising in cooler weather than say exercising in really hot weather, as an example. So blood pressure is meant to respond to all these different things. I don't expect for you to know this, but I just want you to kind of understand that it is meant to be dynamic and a bit fluid. And when we get our blood pressure measured, that's they're just capturing one moment in time. Okay. We like to do this a lot in medicine. We like to run a test, like check your temperature, check your blood pressure, check your heart rate, and assume that that's us all the time. And you're just capturing one moment. Okay. So just kind of know like total blood volume, how elastic the blood vessels are, all of that kind of stuff. Okay, is going to affect the fluid dynamics. The American Heart Association is the organization that gives us guidelines on what we consider to be low blood pressure, nice and normal blood pressure. Nice and normal blood pressure is a systolic of 120 or 80 and lower. And keep in mind that the pressure in they're looking at brachial artery, which is why they cut off blood flow. And then the first sound that goes through is the systolic pressure. And the systolic is when the heart is contracting. When the heart relaxes and refills with blood, that's the diastolic pressure. That's the second number. Okay. And it's actually more dangerous to have a high diastolic blood pressure because that would be the blood pressure is really high in your arteries when the heart is relaxed, as opposed to, it's not good to have high systolic blood pressure. But so systolic, heart contracting, diastolic, heart relaxing and refilling. And then one of the things that the American Heart Association has done more recently, and this is after tracking blood pressure and tracking cardiovascular disease in individuals, they're encouraging doctors and healthcare professionals to be much more aggressive at dealing with pre-hypertension. And they've even lowered the levels in recent years. So American Heart Association, this has been a bit of a moving target. And they really want individuals who are pre-hypertensive to try to bring their levels back down to normal. And then certainly people with high blood pressure, hypertension, to try to treat them, whether it's lifestyle change or medications, to bring those back down to level. Okay. Okay. And know if you want to look this, you can look this up, American Heart Association, if you want to kind of go through some of the details of the recommendations here. Okay. So hypertension is defined as pre-hypertensive would be 120 over 80. Very high blood pressure would be over 140 over 90. And most cases in the United States are considered to be primary or essential cases of hypertension. And what this is meaning, it says here 90% of our cases are considered primary or essential, causes unknown. But we do know the risk factors. We just now talked about some of the risk factors for hypertension. This would be like, let's say a person has a PHEO, which would be a tumor in their adrenal glands. If there's a tumor in the adrenal glands and the body's spewing out all of these stress hormones, that person's going to have hypertension secondary to that neuroendocrine tumor. So primary would be, we know the risk factors, but there's not another disease driving it, is what I'm getting at. Okay, so most of the cases in the US are this primary. Causes and risk factors are multifactorial. And so let's kind of roll through some of these. We've covered some of these already. Blacks are more susceptible to hypertension and cardiovascular disease than white Americans are. And there is a bit of what we believe unfortunately occurred in natural selection when Africans were brought over on slave ships to become slaves here in the United States. And I want us to just kind of think through this a little bit, what happened here. So African Americans in the United States tend to have more hypertension and more cardiovascular disease than Africans from the same area of Africa where the people in the United States are from. And one thought on that was, if on a slave ship, your body could retain salt and potassium and retain fluids, you were more likely not to dehydrate and die, therefore more likely to come to the United States, unfortunately put into slavery, but being able to pass your genes, that ability to retain fluid, pass those genes down the lineage. Okay. Where if on the other hand, you were not able to retain fluid, you didn't have high enough sodium and potassium and be able to hold the fluid in the body, on the slave ship, more likely to dehydrate and die, not pass those genes down the lineage. So the genetic makeup of Black individuals in the United States, does that make some sense? There's a different type of genetic makeup for many of those individuals, which makes them more vulnerable than, say, where they are native from actual regions in Africa. Okay. We know obesity to be a risk factor for hypertension. But again, remember, we talked about so much of this is driven by lack of exercise, so sedentary lifestyle. Dietary salt, some people are salt sensitive and some people are not salt sensitive. And again, that's going to be genetically driven. But just keep in mind that the average person in the United States is consuming this many milligrams a day when all we really need is this many milligrams a day, only 500. Okay. So most people are consuming too much salt. The more likely you're consuming processed foods, because salt is a preservative and salt makes everything taste better. So there's a reason why they put it into preserved foods, and the reason why restaurants put this into food. So more processed food, the more actually adding salt. Some individuals are going to be sensitive to that. Some individuals, it's not going to faze them. Stress certainly makes some sense that it's going to create cardiovascular activity. Certain people in certain moods and certain personality. And remember, we're going to talk a little bit more today about inflammation and the cytokines that drive that inflammation. The cytokines and the inflammation that drives poor mood is also going to drive inflammation and development of cardiovascular disease within the body. Sedentary lifestyle, and caffeine's the same kind of thing like salt. Some individuals are really sensitive to caffeine and other individuals not at all sensitive to caffeine. If caffeine drives blood pressure, then you want to be very careful about your caffeine consumption or try not to consume any at all. Okay, that's a modifiable risk factor. Okay, so that's hypertension. There are both medications and behavioral treatments for hypertension. The behavioral treatments that tend to work nicely, biofeedback. When we do biofeedback, where you're getting physiological feedback from a computer, for hypertension, we usually do thermal feedback. So we put a little device on a person's fingers that looks at their hand temperature. And we know that when we're stressed, our hands tend to be kind of cold and clammy. And when we're nice and relaxed, our hands tend to be nice and warm. And then in biofeedback, you will do either meditation or imagery or progressive muscle relaxation and help those individuals learn how to warm their fingertips, which is warming your feet too. And when you warm the fingertips and you get nice, even blood flow in the body, blood pressure lowers. Meditation is very effective at helping individuals lower their blood pressure and heart rate. Exercise is going to be over time really good at helping heart rate and blood pressure remain low because the cardiovascular system is just nice and strong. Okay, it's nice and strong and nice and healthy. Yoga is really good at helping individuals lower heart rate and blood pressure also. When it comes to the medications, most doctors, when they first, well, the American Heart Association says doctors should be recommending lifestyle change first, as long as the hypertension is not severe, real severe, like they're a heart attack time bomb or a stroke time bomb. Start with the lifestyle behavior, and if that is not enough, then to add medications. And most of the healthcare professionals will start with medications with the diuretics, which make you pee a lot. They lower blood volume. Okay. So if there's any kind of, increase in blood volume that's driving blood pressure, the diuretics tend to decrease that. Some of you women know about diuretics a bit if you use them at all premenstrually. Some women will take diuretics to try to lower some of the water retention that happens premenstrually and relieve some of those symptoms. They can be very dangerous if they're overprescribed though. And then there are other families of medications. I don't really expect you all to know these in this class, but most doctors start with the diuretics. If that doesn't work, then they will oftentimes add another family. And one way that you can assess severity of a person's hypertension, but allow them to keep taking their medications, is how many different families of meds they need to control their blood pressure. So somebody that's on 3 different families of meds, that's much worse blood pressure than, say, somebody who's treated on one, like a diuretic only. So in the research, that's one of the ways that they measure this severity, because they usually don't want to take people off their meds and measure their blood pressure, because that can be dangerous. Any questions here about the behavioral stuff versus the medication stuff? Okay, so stroke or cerebrovascular disease. I'm not going to play this thing here, but there's a new campaign out, and the campaign is called Overreact to Stroke. And again, just like we talked about, a heart attack is a medical emergency. A stroke is an even more immediate medical emergency, because brain tissue dies pretty quickly without oxygen. And what has been happening, it's kind of like the myth that women don't have heart attacks. A lot of individuals around a person who's having a stroke do not recognize the symptoms, or if they suspect something's happening, they oftentimes will downplay it and not react and not call 911. So the most current campaign from the American Heart Association is trying to encourage people, if you suspect at all somebody around you is having a stroke, call 911 immediately. Okay, so that's the overreact part. And then I want to talk about some of these symptoms that people can be having when they're having a stroke. Certainly it's going to depend on what area of the brain is affected and how large the arteries are feeding that portion of the brain. So if it's just a teeny tiny little blood vessel in a small part of the brain, you might get some real short-term weird symptoms, and then it goes away. That's called a TIA. If it's really big artery, you could actually have instant death. But these individuals will report confusion that makes some sense. They're not getting blood flow to the brain, problems understanding what other people are saying, loss of balance. And somewhere in here, one of the points I want to make is these individuals oftentimes look drunk. Okay, can look concussed. They can look drunk. And then that can be misinterpreted sometimes. So loss of balance, somebody's really drunk, they're going to have difficulty walking. They might be reporting numbness, particularly numbness on one side of the body. Trouble speaking, so like slurred speech, which again can look drunk. Visual changes, where they can't see clearly. Feeling dizzy, having a headache. Problems with balance and walking, and then weakness. And then I would like to add here, this isn't on the list, sometimes you will get like paralysis on one side of the body. So the person might be speaking as an example, but only one side of their lips are moving, the other side is paralyzed. Okay. So helping individuals recognize signs, medical emergency, call 911 immediately. Oftentimes 911 will start directing some intervention, you know, like, do you have baby aspirin available? Can you give this person an aspirin and some water? Can they effectively get that down while an ambulance is coming to get them? So some other cardiovascular disease treatments, and again, I don't expect you all to know details about medications, but I do want to talk about some of these that are used. Nitroglycerin dilates blood vessels. It's the same thing that is used in recreational drugs, and I think the term nowadays is still whippets. The whippets were really like a thing in the 80s. I don't know if they still are now. It's the nitroglycerin, and I've known individuals who will actually wear a necklace and have little nitroglycerin tablets in their necklace. So if they start to get that angina and the chest pain, they will pull out and take a nitro, dilates their blood vessels, helps them feel a little bit better. This is the stuff that has gnarly interactions when men are taking erectile dysfunction meds. So if they're taking Viagra and they're taking dialysis, because those things dilate blood vessels and allow for an easier erection, that's a bad combination with nitroglycerin. So those individuals have to be very careful not to be doubling up on this stuff. The beta blockers and the calcium channel blockers lower blood pressure, reduce the demand on the heart. The vasodilators expand narrow arteries. Anticoagulants. You all may have heard of some of these names like warfarin or heparin. If there's a blood clot, they are given these medications to help break up the blood clot. They've got to be very careful about not using these medications when people are bleeding, because it'll make them bleed internally much more. So the challenging part when a person is having a stroke, usually it's the ischemic stroke where there's a clog. But what you got to be careful about is that you don't want to be giving them medications that treat the ischemic stroke to somebody who's got a hemorrhagic stroke, who's got a bleed. Okay. And then aspirin are blood thinners. I gave blood the other day, not my favorite thing to do, even though it's the right thing to do. And they always inquire, have you been taking aspirin? Because if you've been taking blood thinners, they do not want to draw your blood and help you bleed out. So that's one of the meds that they regularly will screen for when you donate. Okay, some compliance issues with some of these medications. One of the interesting things about hypertension, this is why ideally we're getting screened and having our blood pressure monitored, is it doesn't tend to create pain. It's not like you feel it, okay? And pain can be very adaptive because it can point you to problems, it can point you to illness. And usually individuals do not feel hypertension. And then oftentimes they are prescribed these medications that create these side effects. And side effects could be things like feeling depressed on a blood pressure med, having sexual dysfunction, not being able to become aroused and have sexual performance like one used to, feeling tired, feeling dizzy. And one way of thinking about these side effects is they can be very punishing. And so a lot of individuals, they couldn't feel the hypertension. They've been giving these meds that create these side effects, and then they don't like the side effects, so they stop taking the medication. Unbeknownst to them, their blood pressure rides way too high, and then that could be promoting heart attacks and stroke. And then not to mention the expense, all meds have costs to them. Okay, so I don't want to talk about that anymore. Okay. In the United States, we really like our surgical treatments for, particularly for heart attacks or pre-heart attacks. And let's talk about the two types of surgeries that are regularly performed. Coronary artery bypass and grafting, which we just normally shorten to be bypass surgery. If you've ever heard of somebody having bypass surgery, and then it's bypass surgery times how many arteries they had to bypass. Surgical abbreviation is CABG. Nowadays, they are doing some CABG surgeries with small incisions, but historically, bypass surgery, they cut through the pectoral muscles, split the ribs open, get in there, find the clogged arteries, take a vein from the leg, and wherever the clot is, they will just, it's kind of like a detour on a road. They will bypass around that clogged artery to keep the blood flowing. Okay. This is more often used when you've got multiple coronary arteries that are affected and they're highly blocked. And we do this on a regular basis here in the United States. Okay, some of you have known individuals who've had this bypass surgery. It's a long recovery. You've had your whole chest opened. It's going to take a while for the heart to heal. Interestingly, in the US, we give this when individuals are well insured and they have this diagnostics. We give it to people immediately. In Canada, in this one study where they compared people in the United States with this level of severity to people in Canada, they get put on a wait list because they ration their medicine. It's socialized medicine. So they're trying to use their dollars in their medicine to benefit the most people, as opposed to very expensive dollars just to save a few people, like our healthcare system tends to do. You would think Canadians would be dropping off like flies, having heart attacks when they're put on this waiting list, as opposed to getting these surgeries right away. But in one study that looked at the two countries and the results, there was no difference in death rates for people in the US versus Canada. The second most common type of surgical procedure, and certainly this is done if it's going to be treatable before the bypass surgery, is percutaneous transluminal coronary angioplasty. Most of us, if you've heard about this, you've heard of this called angioplasty. And just like they do the angiogram and they thread through the femoral artery, shoot the dye, take a look under the scan of blood flow to the heart, they thread through the femoral artery, find where the clog is, and they send in, after they've shot the dye and they know where it's at, they send in a balloon that opens up and opens up the artery where it is collapsed and clogged. And then nowadays they learned that a lot of times you would inflate it and then it would just occlude back on itself. So nowadays they will open it up with the balloon, and then they'll put in this little device, this little stent device that keeps it open in that particular area. Okay. I have had a family member who had that done for an artery, and the stent moved out of the clot area. And so it occluded, it reclotted. So they've really got to get it into that area and hope that it stays exactly where it needs to be. In one large-scale study, they found that the stents were no more effective than medications, and then about 40% of these close up again within 6 months. So somewhere in this, in the United States, we regularly perform these surgical procedures. They have not been shown to really improve lifespan for individuals. They are expensive surgical procedures, and unless the cardiovascular disease is addressed appropriately with lifestyle change and appropriately with medications, then this disease process is going to keep getting worse. And so you'll hear about, some of you may have heard, where somebody had one of these procedures done, and then later on they had cardiovascular disease problems again, and they had to have procedures done over again. These are very expensive Band-Aids, is the way I think about it. Okay, it's only getting at short-term cardiovascular disease problems. They're not these miracle surgeries, but yet we're doing a lot of them here in the United States. One of the places at the beginning of the semester that we talked about why study women's health is that for a while there, they were using the same medical instruments on women that they were using on men, and they were not the appropriate size, as an example. So we need to understand that women's, as an example, coronary arteries tend to be smaller than men's coronary arteries because men's bodies tend to be bigger and women's bodies tend to be smaller, as an example. So that's one of the reasons why we want to make sure that we're studying women in our scientific research. Okay. I am a big fan of cardiac rehab. I have done in my career a good bit of supervision of mental health professionals who are working in cardiac rehab. And cardiac rehab programs can be done for prevention when people are a walking time bomb for an event, or they can be done after a stroke or after a heart attack. And most cardiac rehab programs have medically supervised exercise, where an exercise physiologist writes an exercise prescription. There are people assisting them in the exercise, monitoring their blood pressure, monitoring their heart rate, making sure that they're only doing a level of exercise that their body can tolerate and respond to. You don't want to send somebody after a heart attack out to run a marathon. You'll kill them. Okay. And for some individuals, walking a quarter of a mile after a heart attack could kill them. So they make sure that the exercise prescription is written at a level that they can be successful at, they can tolerate, and then they get that training effect where, you know, they've walked a quarter of a mile. It was really hard the first time. And then several times a week, they walk that quarter of a mile. And then it gets really easy because their body has healed and has receive that exercise effect. And then they can walk a half a mile, and then they can walk a mile. Does that make sense? And you're building up that nice exercise effect, but you need the medical supervision in a cardiac rehab program. Also address stress, also address nutrition. So there's lots of different lifestyle aspects that are addressed in a cardiac rehab program. The challenge that we have in US culture is getting a person, either if they're a walking time bomb or after they've had a heart attack, into a cardiac rehab program. It's not an automatic thing. And the research has found that after a person has had a heart attack, they've usually been in the hospital and they get discharged from the hospital. They're healthy enough to be discharged. If on their discharge summary, which is usually given to them in paper, it says, go to a cardiac rehab program, here's the contact information to get enrolled, and they have a healthcare professional. This is usually the cardiologist or the cardiologist's nurse says, I want you to go to a cardiac rehab program. They're really effective in helping people heal up after a heart attack. If they get both of those things, 74% of the people go. If they only get the electronic discharge recommendation or the professional's recommendation, 50% will go. Whereas only about 29% go with typical care when they don't get either of these things. So it's really simple intervention, you all. The number one reason why, I'm going to back up here, the number one reason why women of the right age go and get a mammogram is when their healthcare professional says, it's time for you to go get a mammogram. And then most women are like, okay, I'll do it. And if they're given a phone number or they're have an appointment made for them, they're a lot more likely to go. It's just, this is some real simple psychology here. Okay. And cardiac rehab programs are quite successful. So it's one of these things where in our culture, ideally, we're seeing 100% of people who are ticking time bomb, or 100% of people who've had a cardiac, a heart attack. 100% should be going to these programs, but they're not. Okay. With this supervised exercise, these are some really beautiful effects. We get between 15 and 28%, this is across different studies, a reduction in all causes of death for going to a cardiac rehab program, and anywhere between 26 and 31% reduction in future cardiac events like heart attacks and deaths. So this is a really strong effectiveness from a program like this. Okay. And they're not very costly. Cardiac rehab programs are a lot cheaper than those surgical procedures. You've got a physician on staff, you've got nurses on staff, you usually have a nutritionist, a psychologist, you've got gym equipment or a track for people to walk on, they're checking blood pressure and things like that. People come in and they get their exercise prescription, they go and do their exercise, it's supervised, they meet friends at times, and then they go home, kind of thing. So it's just, you know, it's a intensive lifestyle change that's happening within a medically supervised area of the hospital. So like our local cardiac rehab program, as an example, is housed in the wellness center. In Watauga, it's not in the hospital, it's over in the wellness center, as an example, where they've got all the exercise equipment, they've got the pool, and that's where the nurses and the exercise physiologists and the mental health professionals, that's where they all go to meet with these patients. Any questions about cardiac rehab? We should be using it a lot more. Okay. Other lifestyle components that are addressed. Most individuals who've had a heart attack, if they were a smoker before, they've had to quit because they've been in the hospital and they haven't been allowed to smoke. But a lot of individuals end up resuming smoking. And so if a healthcare professional doesn't intervene and try to keep them from resuming their smoking or relapsing in the future, many of these individuals are going to resume their smoking. The idea with the heart muscle, the more that you exercise it, again, at the appropriate level, the more the muscle becomes strong and it heals. Like it's capable of healing itself given the right conditions. And one of the ways, we talked a lot about fitness when we talked about obesity. One of the best ways of determining your fitness level is what is your heart rate upon awakening in the morning? Because the lower your heart rate is upon awakening in the morning before you get up and move around, that's an indicator of how strong your heart is. So think about if you've got this really weak heart, it's going to if it's really weak, it's going to have to beat a lot to be able to get enough blood flow. If it's nice and strong, it's going to beat really slowly because it's getting so much more blood volume out of every pump. And the best way to train your heart and strength is to get that cardio, to get that aerobic exercise and make that heart work during the exercise. And then it's just nice and strong and it can work nice and slowly at rest. Does that make some sense? So fitness can be measured with heart rate in the morning. Okay, I want to talk about Dean Ornish. I am a big fan of Dean Ornish. And Dean Ornish is an interesting cardiologist because he had his own psychological history. He became suicidal in college and got therapy. And so he's one of those medical doctors that very much appreciates integrated medicine and appreciates mind, body, and appreciates behavior. And in his lifestyle heart trial, this is both men and women, these are the ticking time bombs. So these are not people that have had heart attacks. These are people that are about to have a heart attack or stroke. He gets them enrolled in his clinical trial. The people that get assigned to the experimental group basically get a cardiac rehab program pre-event. The people that are referred to the randomly assigned to the control group are getting treatment as usual. And so all of these people could be, say, on medications, but these individuals are getting the lifestyle program in the cardiac rehab. The control group, they are not getting it. 1 year follow-up after these patients are randomly assigned, people in the cardiac rehab program had a 91% reduction in angina, chest pain, 4.5% improved in stenosis, which is how narrowing and blocked the arteries are. So their arteries were more likely to be open and functioning. A huge reduction in their low density lipoproteins. And compare them 1 year out to the control group. These folks had a 91% reduction. These folks had a 165% increase in the frequency of angina. 5.4 worsening in stenosis, whereas these folks improved, and only a 6% reduction in their LDLs when these folks had a 37% reduction. So basically, if you get the cardiac rehab as prevention, it starts to reverse the cardiovascular disease. If in prevention you're getting treatment as usual, which is normally medications, that cardiovascular disease tends to worsen. Now, this is 1 year out. Let's look at 5 years out. And there's Dean Ornish. Also, with his interest in mind-body medicine, he even wrote a book. I haven't read his love book. I've read some of his other stuff, but he even wrote a book about love and how important love is and human connection and relationships. So he's like this warm and fuzzy cardiologist is the way I kind of think about him. 5 year follow-up, the experimental group still had improvement in that stenosis and that narrowing. And there were on average 25 cardiac events, but the control group, 27.5 worsening of their stenosis and a lot more cardiac events in the treatment as usual patients. So basically what this says is that for these ticking time bombs, A cardiac rehab program for prevention reverses their cardiovascular disease. It is very effective. Without the lifestyle change and the cardiac rehab program, this cardiovascular disease keeps progressing and getting worse, is what this is saying. So problems with treatment as usual. I won't expect you to know raw numbers, but it's expensive. Coronary heart disease is very expensive in our healthcare system. The preventative programs, like I said earlier, cardiac rehab for prevention or cardiac rehab after an event is still a lot cheaper than these surgical procedures. So the preventative, 18,000, treatment as usual, 47,000, saving almost $30,000 per patient by getting them to a preventative cardiac rehab program. I wish in our healthcare system, we could send anybody with morbid obesity who has health consequences, anybody who has type 2 diabetes with health consequences, anybody who's got metabolic syndrome, anybody who's got pre-existing cardiovascular disease. We should be getting all of these people to these cardiac rehab programs because the data is just so nice, okay? And it saves money and it improves quality of life. I've known people coming out of cardiac rehab programs who, you know, they talk about, and this is what the mental health professionals do a lot of, after they get exercising and changing their diet and they're feeling less depressed or less anxious, the mental health professionals pointing a lot to, is your life better now? And then a lot of times these people are like, oh yeah, you know, like I could barely walk a quarter of a mile and now I'm running 5 miles a day kind of thing. Or I can, you know, toss my grandchildren up into the air and I feel good enough to go on vacation now. Those kinds of things of really helping them realize that the lifestyle change improves their quality of life as well as improving their medical health. So we should be doing a lot of this stuff. Other problems with the treatment as usual, we're doing a lot of bypass surgeries every year. Within 5 years, if people live after their bypass, the arteries are clogging up again. After 7 years, 80% are blocked again. Same thing with the angioplasties. We're doing a lot of those, and a lot of them will reclog within 4 to 6 months. Again, expensive Band-Aids is the way I think about these. They're not, if they were miracle Band-Aids, I'd be, yeah, let's do the miracle Band-Aids. But they're not, they're expensive Band-Aids, and meaning Band-Aids working a short period of time. Dean Ornish's research, if individuals continue with the lifestyle change, and most people do because they feel so good after they've done the cardiac rehab prevention program and they're feeling better, they continue that lifestyle change for the rest of their lives, it can continue to reverse the cardiovascular disease for them, whereas otherwise it's continuously worsening for these individuals. Okay. US diet, just to give you a little bit of a flavor for what Dean Ornish does with his program, he takes his diet very seriously in cardiac rehab, to the point of the typical American diet. A lot of people are eating a lot of saturated fat. He gets their dietary fat, with the help of these registered dietitians, down to 10% of their calories from fat. And I can tell you, to get to 10%, that's very low fat in the diet. You have to go vegetarian, if not vegan, to get that low. Okay. So cutting out animal products to be able to get that low. But again, a lot of these patients will talk about like, oh, I didn't think I could give up meat, or I didn't think I could give up cheese. I would have difficulty giving up cheese. I love cheese. A lot of these folks will say like, oh, I didn't think I could give it up. But after I gave it up and I started feeling so much better, I have so much more energy. I feel so much better. A lot of them, and then a lot of them will say that on this reversal diet, they can eat all they want, you know, like really eat and satisfy their hunger because they're eating foods that are high in complex carbohydrates, pretty low in protein, low in fat, low in cholesterol. And doesn't it make some sense, you all, that if you stop consuming the dietary fat, your body's going to burn your fat stores, but it's going to pull the fat that's inside the cardiovascular system out of the body to use it for energy. It's like a cleansing, if that makes some sense. Whereas if you've got cardiovascular disease and you're consuming a lot of this dietary fat, you're just feeding it. You're feeding the atherosclerosis. Okay, so again, kind of you are what we eat. Rainbow diet over here, the typical US brown diet over here. Okay, other lifestyle aspects. I can tell you typical cardiac rehab programs, like the local program, they don't go hardcore in the nutrition. Whereas I've seen some other programs that do, the one in Ashe County as an example, they go hardcore with their lifestyle change for their patients out there, and a little less hardcore here in Boone. Dean Ornish, so typical programs try to get them less than 30% of their calories and fat. Dean Ornish all the way down to 10. He has a stress management component, and he even does group therapy in his rehab program. Weight management, diabetes management for patients that have diabetes. And so again, all of the programs have to have certain components to them for their accrediting process. But some programs tend to kind of go light on the behavior change, and some programs tend to go very hardcore. I watched when I supervised the mental health professional down in Wilkes. I was sitting with the registered dietitian when she was counseling one of the rehab patients, and a bunch of the rehab patients had made friends, and they would go to this diner. So they come in and exercise in the rehab program, and they go to this diner. And I still remember the dietitian saying, okay, well, we need to talk about what you're ordering at that diner, she said, because the only thing that I approve of that you eat on that menu is the napkin. Because it was a greasy spoon kind of diner. And what she ended up counseling the patients in doing is ordering very specifically and asking that they include certain foods on their menu that they ordinarily didn't include. Fruit, oatmeal, yogurt, as an example, as opposed to getting, say, sausage and pancakes and scrambled eggs, that type of thing, or bacon, which is pretty typical. This slide repeats. You all know about the nurses health exam study, where they track these women nurses over time, and they found that the women that had the very healthy lifestyle decreased their risk of coronary heart disease by 82%. And you know the punchline, only 1% of the nurses. Some other components of prevention for cardiovascular disease. I think we've covered all of this stuff. The only thing I haven't covered here is the literature on alcohol shows that alcohol in moderation, which usually is defined as 1 drink a day for women, up to 2 for men, actually seems to be effective in preventing cardiovascular disease. Heavy levels of alcohol and no alcohol consumption add a bit, well, heavy levels add a lot of risk. No alcohol consumption adds a little bit of risk. Okay. Physiologically, the stuff that we're monitoring, I think you all know this stuff by now: the cholesterol, the blood pressure, the glucose, and the body fat levels. So I'm just going to kind of cruise through this slide. I do want to talk about a health risk appraisal, though. You can get online and do one of these, find a health risk appraisal if you want to do one. The nurse practitioner that I see for my yearly checkup, she does this every time I go in for a checkup. And it's a computer program where they use this population level epidemiological data. And you enter your information, or your doctor or your nurse enters the information, and it includes stuff like your age, your sex, how much you exercise, what your nutrition tends to look like, are you a cigarette smoker, what's your body weight, and then adding in physiological data. What's your blood pressure, what's your heart rate, what are your different cholesterols, your HDL, your LDL, that kind of thing. And basically what it does is it takes an individual with all of that personalized data, and it finds you in the population epidemiological data. And then it spits out information that is easy for patients to understand. So as an example, it could spit out your health age. So let's say I am a healthy 45-year-old woman, and I go for my checkup, and they run a health risk appraisal, and it says I've got the body of a 35-year-old. And then your doctor says, keep it up, your nutrition, your exercise, keep it up, because your body looks younger than you are. But then imagine if you're working with a patient who just had a heart attack, and let's say she's 50 years old, just going through menopause. She doesn't have a healthy lifestyle. She gets her health risk appraisal back, and she's 50. What did I say? She's 50. Let's say it says she has the body of a 60-year-old. With the appropriate counseling and the appropriate motivation, it's like, oh man, this smoking and this high cholesterol and this lack of exercise is really caught up to you because you've got a body of a 60-year-old when you're only 50 years old. You want some help with that. That'd be a really good candidate for a cardiac rehab program, as an example. It can also give people, it can run these simulations and can give them an attainable health age. So let's say my 50-year-old woman, like, I really want you to go to this preventative cardiac rehab program, and let me crunch these numbers here. You're 50 years old, you got a 60-year-old body. If you do a cardiac rehab program and do all the stuff in a year, I think we can get your body down to a 51-year-old, your appropriate age, as an example. And that's, again, that's information in a way that people can oftentimes absorb it and can be very motivational along with the appropriate counseling. So health risk appraisals are good to use. Some other things, we see a lot of mental health issues correspond comorbid with cardiovascular disease. Even so that part of the reason why mental health professionals are required in a cardiac rehab program is to do screeners for people's mental health, screen for depression, screen for anxiety disorders, screen for substance abuse disorders, screen for eating disorders, particularly binge eating, that type of thing. And then treat those individuals, treat them if they've got a mental health issue while they're in a cardiac rehab program. Just as an example, in one study found for a person who had a second MI after a first heart attack, an MI heart attack, people who were depressed relative to people who were not depressed were 4 times more likely to have another MI. So, depression and anxiety are independent risk factors for predicting another cardiovascular event. And to boil all of that down, I've got here on the next slide, so I'll go ahead and go over here. When the body detects problems, so cardiovascular disease building up inside the body, it's going to communicate. These cytokines, these communicative hormones, are going to communicate and say, hey, we need an immune system response. And then these are pro-inflammatory. Inflammation, meaning you've got an immune system response that's happening, is meant to heal the body from the inside out. But just like we've already said, chronic inflammation, an immune system response is meant to be a very short-term response. A response, inflammation, heal, retract. When the immune system response doesn't cut off and a person gets chronic inflammation, that's going to drive their cardiovascular disease, and it's going to drive their mental health issues. So just like we've said that neuroscientists talk about how believing that mental illness is an inflammation process in the brain, cardiovascular disease is an inflammation process in the entire circulatory system. Okay. We know that patients who are anxious and depressed tend to have more difficulty adhering to a cardiac rehab program. And so it is important to diagnose this and treat these things. And for a lot of individuals, once they start exercising and managing their stress and eating more healthfully, not only does their body heal from cardiovascular disease, their mental health improves. And that's why I talked about how mental health professionals want those patients paying attention to, how are you feeling? You were down a couple weeks ago when I saw you. Has your depression lifted at all, or are you still feeling pretty depressed? And a lot of times they'll say, oh man, I've never felt so good in my life. And it's like, yes, keep it going, keep it going. Okay. So the cytokines are the mind-body connection, okay? When they kick in, they are meant to be short-term healing, but then they're meant to retract. And when they keep going, an unhealthy lifestyle keeps them going, then we're going to have both medical and mental health issues for people. And I think, yes, that is Okay, we have covered a lot today. And I know I see I have run over. Are there any questions on cardiovascular disease in women before we get done today? Okay. We will cover cancer during our next lecture. And I know for those of you who've had my health psych class, there have been a lot of parallels so far in the health psych class and the women's health class. Next week, we start the girly stuff. Okay, so next week, we're going to really start talking about gynecological stuff, menstrual disorders and fertility, move into pregnancy and delivery. So much more of what makes women unique in their medical needs and their mental health needs. Okay. All right. Good to see everybody. Y'all take care. Bye.